lung diseases that share the same pathophysiology, which we'll talk about, but they're all very different. So the pathophysiology, they can have a non-specific inflammatory reaction in the lungs. It may involve the alveoli as well as the interstitium. And it's the interstitium that kind of creates the structure around the lungs. The interstitium can become infiltrated with inflammatory cells, and therefore it can cause these fibroblasts that proliferate and then manufacture an increased amount of collagen. So if you know, if it's collagen that makes our tissues more firm and hold their shape. And so when there's too much of that, the lungs get too stiff. So inflammatory condition can be characterized by edema and infiltration of white blood cells, and that can go into the alveolar walls and interstitial spaces. Bronchial inflammation and bronchoconstriction can be present. So what happens in this immune reaction is that macrophages, and you remember those are the type of cells that engulf pathogens. They recruit polymorphic nuclei that release enzymes, and it's those enzymes that can cause the damage. Other chemical mediators will also be released. And you know, those chemical mediators are the ones that really get in there and cause the inflammation, and they damage the alveoli. And then all of those proliferation of the fibroblasts that cause the increase in collagen is what causes a fibrosis. As you can imagine, fibrosis, when you're talking about gas exchange, that's a major impairment to gas exchange. So in the early stages, one can see patchy alveolitis, and alveolitis just means inflammation of the alveoli with cellular infiltrates, distorting the alveolar walls, just creating a lot of thickness and edema. Once again, impairing gas exchange. Cellular infiltrates forms neutrophils, macrophiles, lymphocytes, and eosinophils. On pulmonary function, what you'll see then as a result of all of this thickening and fibrosis and edema is a restrictive lung component. Once again, like we talked about, ARDS is a restrictive lung component. All of the interstitial lung diseases are restrictive lung components. So they will show a decrease in vital capacity, functional residual capacity, and overall total lung capacity. Your forced vital capacity will be low, and then your FEV1 over your FVC, so your ratio will be normal or increased. And the reason for that is because if you remember in obstructive diseases, the forced vital capacity will be low, but so will that FEV1, because when you're exhaling, your bronchi tend to collapse, and you get that overinflation, and the patient isn't able to get all that breath out. Well, that's not at all the case in a restrictive lung disease. In a restrictive lung disease, the lungs are, if you can think about it, the volumes are decreased because of that edema and restriction on them. So the patient has a hard time getting that breath in, meaning they're going to have smaller compressed lungs. So if they can't get the breath in, when they go to get that out, it's not that they're trapping air in, they just didn't bring enough in anyway. So when you're looking at a forced exhalation over the whole breath, that ratio will be normal or even increased in a restrictive lung disease. So if you're looking at your spirometry, you always look at your forced vital capacity, your FEV1, and that ratio. In the restrictive components, your FVC will be low, your FEV1 will be low, and when we say low, according to ATS standards, less than 80%. And then that FEV1 over FVC ratio will be normal and increased, and that just means 70% or greater. So signs and symptoms of interstitial lung diseases can be nonspecific. In general, patients can exhibit a dry, non-productive cough, progressive dyspnea, rapid shallow breathing. This is something that you'll see that's consistently on a lot of descriptors of interstitial lung disease are these Velcro rails. So if you think of Velcro, think of little kids as shoes, maybe adults as well. We might still have some Velcro, but we probably don't wear Velcro as much. But if you can like think of putting your ear up and opening up that Velcro, that's what it sounds like, these really fine rails. And that's just because it's air trying to get into those small airways and open them up. Patients can exhibit clubbing, digital clubbing, and that is from the progressive hypoxemia that they're experiencing. And digital clubbing is where, if you look at the end of their fingertips, the nail bed will be a lot bigger, and it'll look like it'll have little clubs at the end. And that is as a result of chronic hypoxemia. Patients can be cyanotic. Once again, another sign and symptom that they'll exhibit from hypoxemia. And then the chest X-ray will show bilateral interstitial infiltrates. Okay, so these infiltrates where there's not good gas exchange happening. And of course, the chronic hypoxemia is a result of the impaired gas exchange from all of the thickness and inflammation and restriction in the lung. So diagnosis is usually from a lung biopsy, and that can be taken via bronchoscopy, transbronchial, or they might even have to open up the chest and go in surgically and remove a piece of the lung. And then just determining the response to therapy. So the more inflammatory cells and the less fibrotic cells, the better the prognosis, because fibrosis is a chronic thickening.
Kaya had a question.
Oh, sure. Yes. And you guys go ahead if you do have a question. I can't see your screens at all, so just take your mute off and ask.
Is it always bilateral?
Okay, no. Okay, yes and no, both. That's a really good question. So we're going to talk about some specific diseases, like take, for example, rheumatoid arthritis, sarcoidosis, where there's actually nodules formed. But in general, it's going to eventually take over on some sides. Now, if it's just a nodule, say from like rheumatoid arthritis, like there's actually a case study at the end of this. It could be just specific to one area. But generally, when you look at an ILD, like the most common one would be like interstitial idiopathic pulmonary fibrosis. That's going to affect both lungs. So yes and no, as I said, there could be involvement if it's specific nodule specific only, but in general, you'll see bilateral spread of inflammation. Good question. So treatment in general, as I said, there's some sources say over 100, some sources say over 250. So treatment, there's going to be a lot of variation between diagnosis. But in general, think about corticosteroids. From a respiratory standpoint, a lot of times these patients will be on oxygen therapy chronically. Mechanical ventilation, if they're in respiratory failure. Pulmonary rehab to help live with this disease, and then a lung transplant in some cases. And then I also have up here plasmapheresis, and that's where that's going to be only specific to a few diseases, and that's where the blood gets, it's almost like dialysis, but the blood gets taken out some of those inflammatory cells and IgEs specifically get taken out and then get put back into the body. So there's a lot of different ways to categorize these diseases. Your book on page 834 kind of has it broken down, a really nice table to how to categorize these. I just have them broken up into connective diseases, idiopathic interstitial, and idiopathic, if you guys remember, just means doesn't know how it happens. So connective tissue diseases, you might have heard of some of these, and some of these you might have never heard of in your life. Scleroderma, rheumatoid arthritis. I'm kind of embarrassed recording this because the pronunciation on a lot of these is not correct, but I'll do my best. Jorgen's syndrome, polymyositis, dermatomyositis, systemic lupus erythematosus, or you've probably just heard of it called lupus before, sarcoidosis, and then cryptogenic organizing pneumonia, BOOP, lymphocytic interstitial pneumonia, and then a really common one is your idiopathic pulmonary fibrosis. That's one you might have actually heard of. It's a lot of times just shortened to IPF. And then there's different types of idiopathic pulmonary fibrosis. So we're going to talk about some of those, but if you guys can think about these, I'm not going to have you memorize every different type because, as I said, they're treated kind of and lumped together in a lot of different categories. And I have another PowerPoint on something called pneumoconiosis. And pneumoconiosis is just a different type of interstitial lung disease that it's from an occupational exposure. So systemic diseases, looking at specific pathologies. Other names are lymphangiomyomatosis, pulmonary Langerhans, histiocytosis, pulmonary alveolar proteinosis, which is another one that's a little more common. Ones that'll cause pulmonary vasculitides, such as Wegeners, Churg-Strug's, lymphomatoid granulomatosis, and then you might have heard of other ones: Goodpasture syndrome, idiopathic pulmonary hemosiderosis, and chronic eosinophilic pneumonia. What do you think chronic eosinophilic pneumonia is caused from?
Allergies and asthma.
Yeah, or allergies to something. So maybe not really as an etiology of asthma, but just in general reaction to something. And it could be environmental, and a lot of times people don't know. So I am going to talk about a few of these interstitial lung diseases that you might see a little bit more commonly. So sarcoidosis. Who can tell me who has passed away from sarcoidosis that was a famous comedian and actor? Okay, I'll just tell you. Do you guys remember Bernie Mac?
Yeah.
Yeah, he actually passed away of sarcoidosis. So sarcoidosis is a multi-system granulomatosis disease, meaning it causes little granulomas all over the body. And these granulomas can be on or develop in the lungs, lymph nodes, liver, spleen, skin, eyes, and small bones of the hands and feet. Patients can have enlargement of mediastinal lymph nodes. And hallmark signs of this is just elevation of the IgM, IgG, and different IgA cells. Women can be more affected than men, and it is more common in African Americans. And as far as when it can develop, commonly it can develop between 10 and 40 years old. A lot of times patients are asymptomatic. There's different stages. So in stage 1, cough and dyspnea on exertion. Stage 2 can get more advanced and need steroids. And then stage 3, patients can actually have fibrotic lungs. If it affects the eyes, they can have blurred vision. If it's on the skin, they can have something called erythema nodosum, which is a rash, and it can't even develop into like abscesses. And that's just little nodules on the skin. And then if they have liver involvement, they can have jaundice. So it really can present in different ways depending on where the nodules are. But a lot of patients do get pulmonary involvement, and we'll see this quite a bit. And if you work in pulmonary rehab, you'll see a lot of patients with sarcoidosis.
With sarcoidosis, then, is it just like inflammation? Is that just really what it is? Just like inflammation of the granulomas?
Well, yeah. So what a granuloma is like inflammation of tissue. And so it becomes just like a little built up clump. I guess that's an easy way to describe it, a built up clump of cells. And then when, if that gets into the lungs, all these nodules, once again, that's just going to cause fibrosis, which is thickening, and it's going to, impair gas exchange. So these patients can be really hypoxemic.
So there's really like lack of ventilation happening within the alveoli.
Yeah, okay. Exactly. Yep. Very good. Other manifestations: chills, fever, malaise, cough, dyspnea, cyanosis, tachypnea. Once again, rales, where the alveoli are really trying to open up. This one, I want you guys to remember this. So with sarcoidosis, it's one that, due to it, becomes very fibrotic. Pulmonary function testing will show a restrictive pattern, but it'll also have a low DLCO. And the DLCO is the diffusion capacity of the lung, and that's measured by inhaling carbon monoxide. So sarcoidosis is one that you'll probably see on, say, take for example, NBRC exam that might say, okay, which lung disease could have a restrictive lung component accompanied by a low diffusion capacity, and that's sarcoidosis. Can anybody kind of compare and contrast that and remember back to module 1? Can you guys think of one disease process that the pulmonary function shows an obstructive pattern and a low DLCO?
Can you repeat that?
Yeah. Okay. So back in module 1, we talked about a obstructive lung disease that PFT showed an obstruction and also a low diffusion capacity. Thinking back to the diseases themselves and the pathophysiologies of those, can you guys, mod 1, we talked about the obstructive disorders such as COPD, asthma, cystic fibrosis, bronchiectasis.
Was it COPD?
It was. Now, let me have you answer that even more specifically. There's 2 disease processes that make up COPD: chronic bronchitis and emphysema. Do you guys remember which one of those showed a low DLCO and why?
Emphysema, because the blebs.
Yes, emphysema, because of the loss of the destruction of the tissue itself. So if you guys can remember all those little networks that hold together the alveoli, they get broken down and degraded, and then there's not enough surface area. So there's a really low impaired DLCO, diffusion capacity, in emphysema as well. So in emphysema, obstructive component and low DLCO. Sarcoidosis, restrictive component, low DLCO. So chest x-ray on patients with sarcoidosis will show chronic signs typical of fibrosis. Diagnosis can be with patient history, and then of course biopsies. Management, there's no specific treatment to stop it. Symptoms usually subside spontaneous. They can try steroids in some cases, And then, once again, the use of chronic oxygen, pulmonary rehab, those are ways to help manage it.
Can they get a lung transplant, or will they just ruin those lungs too?
Well, that's a maybe. It just depends on lung transplant is one of those things that it totally depends. A lot of times when we talk about ILDs, pulmonary fibrosis patients can get lung transplants, but not as common with sarcoidosis because they could have involvement elsewhere. And if they're already at the point where their lungs are really involved, then it might be in all their lymph tissues and on their body. So not generally.
Okay.
Diagnosis, a bronchial alveolar lavage. Okay, and that's through the bronch. Tissue biopsy, just showing, microscopically showing those granulomas with little or no necrosis. You can look at chest X-ray. There'll be changes with lymph nodes, pulmonary lesions, bilateral lymphadenopathy, parenchymal pulmonary infiltrates. Pleural involvement is rare, but honeycombing can be involved when it gets to be in advanced stages. So your book has good pictures of honeycombing. You can see that on page 836 in the chest X-ray. I have it coming up as well. But a lot of these conditions will have the honeycombing chest X-rays. Okay, so also, as I said,
what did you say that BEL stood for under the diagnosis?
Oh, yeah, good question. Bronchial alveolar lavage. So that's getting a bronchoscopy and taking some normal saline and flushing it down the bronch, and then getting a sample of the secretions, the mucus, and the tissues down in the tracheobronchial tree, so they can put that under a microscope and look at it.
Okay.
Yeah, good question. So in early stages can show enlargement of the lymph nodes in the mediastinum. As it continues to progress, it can cause damage to the lung tissue that heals by scarring. The film can show milky and granular appearance in normally dark lungs. So here's advanced scarring via chest X-ray. So as you can see, that's pretty involved. It's on both sides. It's bilateral, and you can see how gas exchange will be extremely impaired in this patient.
So the black, is that air then?
Yeah, black is air.
Okay. So
and
it's
then
not pneumothorax, it's just air, and this is
right. Scarring. This is not air. Yeah. So all of this throughout both sides are what we call infiltrates. And so infiltrates can be from a lot of different reasons. It can be fluid, it could be scarring, it could be atelectasis. But when there's little pieces like that all over, this patient is it's really from all of that scarring. So, you wouldn't just look at this X-ray and say, I think that's sarcoidosis. You'd have to also, look at patient history. They would have to have a diagnosis at this point. A patient that has this X-ray would come in, and they would be extremely hypoxemic, and they would be very dyspneic. Okay, they would be they would be tachypnic, they would be using their accessory muscles, and probably be cyanotic as well.
okay.
Yeah, that's pretty advanced. Another type of ILD is called eosinophilic granuloma, or histiocytosis X. It shows, once again, many scattered small interstitial granulomas. It can be just below the visceral pleura. Granulomas are composed of these histiocytes. It's a type of macrophage with rod-like structures called X bodies in their cytoplasm. This can most commonly affect patients 20 to 40 years old or earlier, birth to 15 years. And then it can affect males slightly more than females. Wegeners granulomatosis can be a multi-system disorder. It can cause necrotizing granulomatosis, vasculitis, and vasculitis just means inflammation of the vessels in that area. Glomerulonephritis, kidney involvement, systemic vasculitis of small veins and arteries. These patients can get a frequent sinus infection and inflammation of the sinuses. In the lungs, nodules are common in the upper lobes with cavity formation of larger lesions. So anytime you hear cavitation, it can have similar effects as tuberculosis. Wegeners can be an aggressive and fatal disorder, a lot of times seen in older males greater than 50 years. Diagnosis, again, with a lung biopsy. The cells themselves will show lesions with these marked necrosis. The area surrounding will have the inflammatory white blood cells with those fibroblasts. So difficult, bless you, difficult pathology to get diagnosed with.
And hey, Jamie.
Yeah.
Sorry, what did you say that it was similar to in the lungs?
Oh, I said before when anytime you hear like cavitation, that can be similar to tuberculosis.
Okay, awesome.
Yeah, I mean they're different etiologies. So tuberculosis is from a mycobacterium, and then this is just from inflammation from an unknown reason. Patients just have these. So, but those cavitations are just areas in the lung that create little like pockets. And once again, anytime you take away from area of the lung that can participate in gas exchange, there's going to be, significant involvement, and will cause a lot of signs and symptoms of distress. Another one, Churg's drug, similar to eosinophilic granulomatosis. Necrotizing vasculitis involves small vessels of the lungs. These granulomas have a heavy infiltrate of eosinophils, central necrosis, and peripheral eosinophilia. Cavity formation is rare in this disease. Asthma diagnosis can precede the onset of vasculitis, so patients will just, really feel like they're having an asthma attack and that bronchoconstriction. But really, the ultimate problem is the inflammation of the blood vessels in the lungs. Can be a rapidly fatal disease. Idiopathic pulmonary fibrosis. This one is one that you've probably heard of and you will work with these patients. It's a progressive inflammatory disease with varying degrees of fibrosis and severe cases that honeycombing again. Unknown etiology, but it is becoming more prevalent in the population. It can also be called Hammond-Rich. It's more common in males between 40 and 70 years old. Diagnosis has to be confirmed with open biopsy, and it has a pretty high mortality rate, usually in 4 to 10 years of diagnosis. These patients, as I said, will be on oxygen. You'll see these in the pulmonary rehab centers, and these patients can be candidates for lung transplant.
Is the open biopsy like where they actually cut you open?
Yes.
To get, okay.
Yeah. Instead of being able to go down and get it via bronchoscopy. Rheumatoid arthritis. You guys probably had no idea this was categorized as an interstitial lung disease. If there is involvement in the lungs, then it becomes an interstitial lung disease. So it's primarily a joint disease, but this is where patients can develop nodules on the lung. So if you guys see this CAT scan here, here's a nodule, okay? And then what's all of this around the lung?
Looks like air.
Exactly. So, and then what do you think this is sticking down in here into the pleural space?
The needle for thoracentesis.
Yep. So that's actually just a needle or a chest tube. So this patient has a chest tube trying to get the air out. But if you guys see this one, you asked me about if it's always bilateral. Well, that was a good question, because if you guys would see like idiopathic pulmonary fibrosis, it's interstitial, but this one's not, because the nodule is over here on the one side. So males tend to develop rheumatoid pleural complications more than females. So characteristics can be lung involvement may have pleurisy with or without a pleural effusion. They can have interstitial pneumonitis, so just inflammation of the lung parenchyma itself. Nodules with or without cavities. And then pulmonary hypertension secondary to pulmonary vasculitides. So that's just, once again, when we get inflammation and nodules around our pulmonary capillary bed, the blood flow, there's going to be a lot of pulmonary vascular resistance, which can lead to high blood pressure in the lungs. So here's another picture of the honeycombing. You guys can see it. This isn't a great chest x-ray, but you guys can see, there will be darker areas up here where there's actually air. And then around it, it's just like little speckles. And so if you would, of air and non-air. So if you'd think of a honeycomb, you can kind of see how this resembles that. And as I said, there's some pretty good pictures on page 836. Another disease that we can classify as an ILD is systemic lupus erythematosus, or just lupus. You probably heard it just called lupus. Lupus is a multi-system disorder involving the joints and skin. Other organs that can be affected are your kidneys, lungs, nervous system, and heart. Pulmonary manifestations that can arise from lupus are pleurisy with or without an exudative effusion. So if pleurisy is just inflammation of the pleural space, and if it gets too involved, fluid can get into the pleural space, causing the pleural effusion. Atelectasis, diffuse infiltrates and pneumonitis, diffuse interstitial lung disease, uremic pulmonary edema, meaning fluid coming all out throughout the lungs, diaphragmatic dysfunction, infections, and this disease usually responds to steroids. Okay, polymyositis, dermatomyositis. This is a disorder of the striated muscles. It can weaken the limbs, neck, and pharynx. It's dermatomyositis if a skin rash accompanies the muscle weakness. It can occur in females more than males, and it can usually affect two different age groups, like a younger age group before age 10, and then an older one, generally between age 40 and 50. Pulmonary manifestations can occur between 1 and 24 months ahead of the muscle or skin symptoms in some cases. So this is kind of an interesting one, because I had a student one year in respiratory school, and she shared her story, and you'll probably meet her when you guys get into the hospital sometime. She works at one of the local hospitals, and she had this, and she was a perfectly healthy, normal 18-year-old, went to Boulder University, and then just kept getting muscle weakness and just thought, well, I don't know, maybe I'm, just kind of out of shape. And then it finally spread to her limbs and her upper chest muscles. And she actually ended up being in the hospital, trached and vented for months with this. And she did have a permanent she had a tracheostomy for many months, and then finally got that pulled out. Now she's perfectly fine. Came back, went to respiratory schools, working as a respiratory therapist. But this all of these can be pretty rare but devastating disorders. So pulmonary manifestations, recurrent episodes of aspiration pneumonia caused by esophageal weakness or atrophy, and then pneumonia secondary to weakened diaphragm. And then, of course, if the diaphragm gets too weak, they can actually go into respiratory failure. Scleroderma. You guys, this is another one that you may have heard of. It's fairly common. Primarily involves the skin and small blood vessels. It can affect the connective tissue, and it can end up hardening the tissue. It can affect the esophagus, the GI tract, the heart, lungs, kidneys. Esophagus is the most common organ involved, mainly seen in females in their middle age. It can be localized and systemic, meaning it can just affect one organ, or it can spread throughout the entire body. It can cause diffuse interstitial fibrosis, pulmonary vascular involvement. It can affect the pleura and cause pleural disease, and patients can also get aspiration pneumonitis. And then other miscellaneous ones are good pastures, idiopathic pulmonary, hemosiderosis, BOOP, and alveolar proteinosis. So good pastures generally involves two organ systems, the lungs and kidneys. In lungs, there are episodes of pulmonary hemorrhages and sometimes fibrosis. If it's in the kidneys, it can generally cause glomerulonephritis, characterized by infiltration of the antibodies against this, so an anti-GBM. Can be seen in young adults. Prognosis, you can tell after diagnosis in about 15 weeks.
Sorry, did you ever say what BOOP was?
Oh, I'm going to get there.
Oh, okay.
Yeah, sorry, I was going to introductions. Idiopathic pulmonary hemosiderosis, pulmonary hemorrhage filled with macrophages, hyperplasia of the alveolar epithelium. Unlike good pastures, there are no anti-GBM antibodies. This one can often be seen in children. Pulmonary alveolar proteinosis, or AP, it's an uncommon lung disorder of unknown etiology. It's described by excessive accumulation of surfactant in the alveoli, which, if you don't have enough surfactant, your lungs get too stiff and they're unable to open, and so they'll collapse. This one, there's too much surfactant, and it really just goops up the alveoli, and it impairs gas exchange that way. It's often idiopathic. It's commonly seen in healthy men and women between 20 and 50, men more than women. There could be other underlying causes, such as inhalation of silica dust, exposure to insecticides, aluminum, titanium dioxide, any kind of inorganic dust inhalation. It can happen also in hematologic malignancies, mostly myeloid disorders, such as leukemia. It can happen in HIV infection. Pathophysiology for this is alveolar macrophages are unable to remove the excess surfactant. And so that excessive surfactant just progressively builds up and impairs oxygen absorption in the lungs. And diagnosis could be with a lung biopsy or bronchoscopy, or a CAT scan. Treatment's kind of interesting because what'll have to happen is patients will have to go in and get a BAL, or a bronchoalveolar lavage, And that's where they go in and do the bronch and just wash out all that extra surfactant with saline. And then lung transplant may be needed in this condition. So when you think of alveolar proteinosis, too much surfactant need to get washed out with a bronchoalveolar lavage.